out of this webinar. So we want to really get down to what we're here to talk about with insurance. And is this the way my team acts every time I come back from Seacourse? What about yours, Rich?
I don't know where you found that picture, but it wasn't in my office. I can tell you that.
So they're so excited that we came back to this course and we're going to be saving our patients' lives and we're going to help them. And then we tell them, hey, by the way, we're going to have to do some insurance billing for these patients. Furthermore, it's going to be medical insurance billing. And the whole team's walking around like this, worried and concerned about how we got to do this new procedure in our office. And we're hopefully here to wish you good luck with it. We're going to help with that too. And by the way, I can see someone's already put in a question. We'll try to type into those questions as we go. If you have questions, type them into the questions, not into the chat, but into the questions. And if you'd like to ask a verbal question, which we certainly encourage, you can raise your hand, and we'll do that as well. And we will open it up to questions at the end. So we'll try to do the questions along the way, and as many as we can answer. And then at the end, we'll certainly answer all of them, as well as any verbal questions that we have. This is changing, isn't it, Rich?
Well, the whole thing is, Dave, think about when we got into this guy almost 15 years ago, the first guy through the wall always gets bloody, and if you're just getting into this, your timing is pretty good because, it's certainly easier to do this now and to get paid for it now than it was 10 years ago or something like that. But this is different, dental sleep medicine is not quite the same. It's, you got dental and medicine in the same topic there, and so it's just a little bit different. And you got to think about this is a process. It's a learning process. You have to learn a new language. You have to learn a new vocabulary. You have to learn, about the dental devices. You have to learn about sleep studies. There's just a lot of things to learn. And I think you need to give yourself a little bit of latitude, but you also have to have a plan to make this succeed. And as you guys are getting into this, we're glad you're here to learn about the ins and outs of billing for dental sleep medicine.
Absolutely. It looks like maybe we had a little problem with the screen there. We got it working earlier. I think it's working now.
I'm seeing your screen fine.
Yeah. So someone typed in about the screen. I think we've got it going well. So, billing for dental sleep is one of what we call the pillars. As far as what you need to put in your practice, we need to find systems for screening, for testing, and we need a system to basically implement and to manage this as far as the practice goes. And then today we're going to talk about, as we can see here, one of the biggest pillars is insurance billing. And that's a challenge that if you master all these three, what we call pillars of dental sleep, you'll have a thriving dental sleep practice before you know what happened. And you can be like me and Rich, sitting around, our legs kicked up, not doing extraction shots or root canals, and then doing dental sleep all the time. It is really rewarding and fun. It's not without challenges, but it truly can be one of the most enjoyable aspects of dentistry. We certainly love it. So if you want a quick answer on how to do this, what is it? Go ahead, Rich.
No, I'm just saying, who's doing this? How do you do it, right? So the quick answer is just hire somebody else to do it, right? I mean, because there's some ins and outs to this, and I think there are several hurdles. One of the analogies we use when we teach this is think about running around the football field, at your high school, and you got about 10 hurdles, and you got to jump over those hurdles. And dental sleep medicine has several hurdles, and probably the biggest one is insurance billing. So we think it's a great idea to use a third-party biller. There are several out there. You can give us a call. We're happy to recommend one, and that kind of thing. But at least it gets your foot in the door, and it's not such a big hurdle that it keeps you from doing this and saving lives and making money at it and feeling good about it. So that's the quick answer.
Right, and once you get well, we're going to show you how to do this yourself, and we encourage you to, once you get busy doing dental sleep, to do it yourself. We certainly think most offices can. And I think the biggest challenge really is that once we start doing a mandibular advancement device, we're crossing a line. Oh, it went too fast, sorry, into medicine. from dentistry into medicine, and that's where this changes. I talked to someone at the meeting today, and one of the doctors there was saying, I don't know if I'm comfortable with getting involved in medicine and medical. I said, well, then maybe you shouldn't do dental sleep, because the moment you start making mandibular advancement devices for apnea patients, we are doing what is considered a medical procedure. So that's okay. I mean, it's something that we should embrace and not be afraid of. I do think we've been trained a little bit differently. Does this look familiar to you, the ethics that we've been taught as dentists, that you expect to be paid in full for fees? And if not, you declare us to third parties, which in this case are insurance companies. Is that what Rich and I have been in this long time?
We all got that drilled into our heads from day one, right? I mean, the state board reminds us of that and everything. And, here think about you as the dentist or the office manager. We got several different people listening here tonight, and you go to the doctor yourself. How much is this going to cost? Sometimes you can't even get an answer. It's, well, we just bill your insurance, and if they pay, great. If they don't, we send you a bill. Pay it, don't pay it. We don't care. So that's kind of what we inherit when we cross that line from dental into medical. Is this patient perception, okay, of what they expect to pay or not pay, and then that contrasts in a very stark way with what we were taught as dentists. So what does the dental American Dental Association Code of Ethics say? Oh, there we go. So next slide.
Yeah, it basically says that a dentist who accepts an insurance payment under a co-payment as a payment in full without disclosing this to the insurance company, that this payment the patient's making is the full payment. They're considered to be sorry, I'm reading this.
You got it.
To not be reflected in an overbilling. The dashboard's hiding part of what this says on my screen is why I had to kind of remember what it said underneath there. But essentially what that's saying is, look, we accept this money from the insurance company, and that's all we're going to get. We're supposed to tell the insurance company that we didn't collect the rest from the patient. That's what we've been told. That's our code of ethics, and that's the longer you've been a business, the more it's been ingrained. And the physicians have their own code of ethics, the AMA. The code of ethics is almost 180 degrees different from this. It's basically saying that we need to be conscientious of what healthcare costs, and the patients are made aware of this through these payments. But if this co-payment is a barrier to them getting this needed care due to financial hardship, we should. Notice we should forgive or relay. I think the reason Rich has finally made sense to me is, sometimes this truly can be life and death. Medicine, if someone comes in and they have very severe apnea, 75 events an hour, they just had a stroke, they've got 3 stents, and they're allergic to whatever the closes on CPAP, they literally can't wear CPAP for whatever reason, and they're down to their last dime. Are we supposed to say, no, if you don't pay the difference, you go on somewhere else? And we read their name in the obituary the next day. I mean, we really need to help these people out, and I think that's why the code of ethics is a little bit different.
That's happened to us, Guy, right? I mean, that happened to me early on. We were trying to get somebody a gap exception, which we'll talk about, later. And during that time, we got a call from this guy's wife, and that he had passed away. So this is a serious thing. So you've got to look at that. You've seen the medical side. You already know the dental side. So this is one of those paradigm shifts that we want you to at least think about, okay, as you try to figure out how this fits into your practice and what you do. We're here to give you a lot of information. This is not rocket science, but there are a couple of different ways that you can look at it. You got to decide, are you working as a dentist, or are you working on the dental side of things or the medical side of things? So you've seen we got both of those right out of the ADA Code of Ethics and right out of the AMA Code of Ethics. So I think we need to give ourselves a little bit of latitude from what the dental side of that says anyway as we move forward.
Great. Yeah, and I agree, and I see there's a hand raised. We're going to get to some of these questions in a bit. If you're typing in the questions, just type them in, and we'll try to answer them as we go. But we really want to, there's a lot of information to get through. We'll try to get through on time, and we will promise to stay as late as we need to answer any verbal or typed in questions. But, really what this amounts to the patients are coming in, they want the treatment, and they want to know how much it's going to cost them. And is my insurance covering at least part of this? They want to know that that insurance that they have is contributing to this, and that you're the kind of provider that's going to work with their insurance. And that's, if you can get those two answers reasonable for your patients, you're going to do a ton of dental sleep devices. And I think we can help you with that. You can charge cash for this if you want. You can just say, look, I'm not going to mess with my medical insurance, and I'm just going to come up with a cash fee. And that's okay. I mean, that's better than not doing anything for your patients. But I can tell you, you're not going to reach outside your own practice for that. The physicians aren't going to refer you patients if they find out that their patients, that you don't accept their insurance or work with them on their insurance. It's just going to seal that possibility of referrals away. It's gone. It's just not going to happen.
Yeah, I'd like to have a nickel guy for every time I've heard a dentist say, I can sell $10,000, construct, mouth cases all day long, but man, it's sure hard to sell a couple $1,000 dental device. And that part of that really is this paradigm shift between dentistry and medicine, and what we have inherited as dentists practicing in this medical arena now. But there's a lot of things at play here. So when we think about what do you charge for this guy, give us the quick lesson on how you think a dentist should calculate a fee.
Right, I'll go through this very quickly. We also have this in our Dental Sleep Medicine Insider magazine on some of the back issues. You can go and look that up online and see a little bit more detail. Essentially, we want to know how much money you would like to make in order to make this profitable doing dental sleep in your practice as you would be doing another procedure that you would like to do, like a crown or something. And that's how much money you need to collect. You may bill differently depending on your billing model. So an example of that would be that if we had a crown that we charge $1,300, and the numbers don't mean much here, it's just the procedure that we're talking about here. And if it takes us a couple hours of chair time or an hour of doctor time, the lab bill we're out $300, then after the lab bill we have a profit of $1,000, which equates to $1,000 for the doctor time or $500 for our chair time. It's just pretty much simple math. And so if you want to, you can do this with your own numbers, and then you can reverse this, and we can give you some numbers if you're efficient at doing dental sleep. Now, these numbers used to be a lot more in our practices before we had efficient systems in place to make us do this very efficiently and well, and a good job for our patients without a lot of wasted time. Conservatively, my team spends less than 2.5 hours of their time per patient. I certainly spend less than an hour of my time per patient with the systems that we have in place. So what we do is we reverse those numbers. And in this case, you would take a 500 if you want to go by chair time, and that's 500 times 2.5, 1250. As you can see, the doctor time's still 1,000. And you may want to just average these two. Because one thing about dental sleep, if you do this well, it can be much more team driven than something like a crown. The team can do the vast majority of the work, as opposed to a crown. The doctor has to be in there anesthetizing in most states and doing the prep itself. So you just average the two if you want to, and then you add your lab fee, and then that's the fee in this doctor's office that they would need to collect on each case or on average in order to make them happy. And when you do the math on this, Rich, it doesn't come out to, some people think, oh, you're going to get $3,000, $4,000, $5,000 a case for this, and hey, God love you if you get that, but I don't think you need that to do that. I think most practices can be in the $1,500 to $2,500 range of what they actually collect on average for the patient. They're going to do this for which they can sometimes great.
Right, very good. Thank you for going through that, guys. What kind of decisions do you have to make as you look at doing this? So, basically we're going to talk about three things, right? We're going to talk about how you deal with Medicare, and we're going to talk about how you deal with in-network stuff and out-of-network stuff, and then the specific billing systems, okay, as you get into this. You're going to accept assignment of insurance or not. So those types of things. So let's jump. Of course, we're billing medical and not dental. We need to know that. So let's jump right in here, Guy, and I think we're going to start talking about what does insurance cover? As we think about this, does it cover snoring? Have you ever gotten a patient covered for snoring?
No, never.
How about upper
Never
airway
for snoring.
resistance syndrome?
Not that I can recall.
Okay.
So really, what you're looking at. Okay.
I've got one up on.
You know, you've always got a one up me, don't you?
Yeah, I always got a one up. That was somebody had the gold medal plan. Was ex-president of some big oil company or something. But for the most part, we don't get paid for this unless somebody has a sleep study and they are actually diagnosed with sleep apnea. Right? The old code was 327.23. The new code is G47.33. You guys should know that. That doesn't come from us. That comes from the physician who reads the sleep study and makes the diagnosis. What about the other one there, Guy?
I don't think as you have yours is widely accepted. So in general, we're going to go with the G 47.33 code.
Okay, so that's the diagnosis code.
Absolutely. And so before we see our patients, and this kind of goes into some of the other courses we do when it comes to doing consults and so forth, we do need some information. And this can also relate to insurance billing. So we need a copy of the sleep test. In our situation, we need some answers to questions that we do via our web portal and DS3. And those questions help us justify our treatment. They act as our clinical notes, and we certainly want to know what the coverage is for this particular patient. That interact with for their deductible. Basically, we want to come up with an estimate for the patient for the dollar and the amount out of pocket for that patient. Here's what our eligibility check looks like, so we can quickly see what their benefits are. And then the other things that we're always going to need, in addition to the ones I just went over, is a letter of medical necessity and prescription. And this comes from the physician, ideally the primary care. In most cases, that's where we like it to come from. That basically says that this patient is medically necessary to have this mandibular advancement device. And insurance companies pretty much are mandating this on almost every case, so we're going to put it under the always side, and it's just always a good idea to have that, and then you have to have a way to submit that as well. A lot of the dental softwares don't allow for submission of medical codes. You want to talk about the May here, Rich, or you kind of want you lobby to put this one on the other side, didn't you?
Yeah, well, how much is the May? If it's 80%, do we move it over to always, 90%? So, one of the things that you got to think about, okay, is when we think about this, we're talking about, what we need prior to a consultation even. So you think about, as you walk a patient through this process, right? And we want to treat these people, we want to file a claim, and we want to get paid, right? That's probably why we're all on this webinar tonight, right? So if you have the sleep study, the questionnaire, clinical notes, and the prescription letter of medical necessity, you're going to get paid most of the time. If you throw in the authorization, okay, then the odds that you're going to get paid go up significantly. But that's something that you just simply have to find out, right? Does this treatment procedure need to be pre-authorized? And it will tell you, they will tell you yes or no. And if it is, well, then you get the authorization. So we're going to talk about that a little bit more. That's something that we deal mostly with Medicare patients. But, there you've got, if for every patient you had every single one of those things, then you are doing everything that you can do to actually not only file a claim, but to get paid. That's what we're here for, is to learn about increasing our success rates at getting paid for doing the dental classes.
Absolutely. So once we have that information ready, we're ready to get going and make some decisions. And when it comes to Medicare, that's the first decision we're going to have to make. And before we talk about the individual decisions, just understand how Medicare works. Medicare basically does cover dental devices, E0486 now, and what they cover depends on what region you're in, the LCD in other words. And Medicare will cover about 80% of what they allow for your area, and the patient would pay the other 20%, or in most cases, a lot of patients have supplemental insurance that will cover that 20%. You do have to use a Medicare-approved device, For as far as we're concerned, the two that we use are the TAP or the SUAD or HERPS, which are essentially kind of the same device. And those are the two devices, considering the SUAD and the HERPS as one type, that we use in our offices.
So remember, a global fee, you know what that means with a global fee is that it involves everything that you do in treating the patient. You know, Medicare has also said that you've got to, you know, these things have to last 5 years. So we'll get into this, but you kind of got to pick, you know, don't assume that Medicare knows what they're doing. You know, you make phone calls. It's amazing how you can call them and just get different answers to the same question on different days, right? So, but looking at the 10,000 foot overview, and you're just looking down at Medicare, you've got to decide if you're going to opt out or you're going to opt in. And then, thank goodness, there's this kind of in-between kind of weird thing where you can become a DME supplier and a Medicare provider, and you can choose to participate or not participate. So, let's get into it, guy.
Yeah, I like your new slide here. So this, I think, makes it a whole lot easier to understand and to look at. So you're going to go down one of these paths, and we're going to go through each of them. We recommend the middle path, just to cut to the chase on this, because it gives you the most flexibility, and it also allows us to bill Medicare so we can tap into that amount. So I think, first of all, good.
Well, that middle path allows us to balance bill the patient the difference as well, but we'll get into that. So first of all, opt out. How do you do that? What's involved in it? You sign a contract, right? You call up Medicare, you get it offline. It's about 2 pages, I think. It lasts 1 year for each page, so 2 years, right? And when you do this, you basically you're saying I'm not dealing with Medicare at all. So you can't file a claim for Medicare, nor can a patient that you see file a claim for Medicare on their own behalf. That's where this advanced beneficiary notice comes in. And if you think about this, I think really that's designed to protect the patient, isn't it, Guy? When the patient comes into your office, and it's designed to keep the patient from being taken advantage of, thinking that insurance is going to pay for something when in reality they're not going to, right?
Absolutely. I think that's the main purpose. And unless you're just wanting to do cash for your patients, we recommend that you become a non-participating provider. It's a disservice to your patient to not allow them to tap into this money that is rightfully theirs. So, if you want to do this, we want you to understand how, and you can't reverse it. I know there were dentists who did this and now go, gosh, I wish I hadn't. You've got 2 years commitment once you've done it. And this isn't necessarily the easy route either. There's work involved in opting out. It's not just a simple phone call or something either. So to opt in, I know some offices do that as well. And to do this, you're going to become a DME provider with the 855S. And in this case, you're going to accept the Medicare fees as the amount, and you cannot balance bill the patient. But what you will get is 5% more allowable amount on average than if you are non-participating as far as the allowable.
You think 5% more?
A whopping 5% more of the already low fee.
So, if you're a cardiologist, for example, and 90% of your patients are 65 or older, okay, you have to do this. You have to opt in, right? So it's the CMS 460 application. You have to go by their guidelines, accept their fees. You cannot balance bill the patient above what the Medicare accepted fee is. So if you're in a town and you're 62 years old and you are the youngest guy in town, then you might consider doing this, right? But anything less than that, then you probably shouldn't. And thank goodness, we've got the opt-out, we've got the opt-in, and then we have this kind of in-between middle thing. So this is very hard to call it. What do you call this? You'll hear a lot of terms. Are you participating in Medicare? Are you non-participating? And this slide right here, this is really how you need to look at this. we can tell you're a New York guy there. I can hear that siren going now. All right.
Can you hear that? I'm sorry. All night long, all night long I'm hearing that stuff. I can't wait to get back on Anna Maria Island. Sorry for the disturbance.
So you opt out 2 years, right? You opt in, and thank goodness we have this kind of in between here where we can choose to participate or non-participate on a case-by-case basis. Okay, we're still going to do the DME. The 855S is the application that we use. Okay, now we get 5% less, right? Even if we participate on this arm, because we've not opted in. So that 5% isn't a deal breaker when you're talking about, $50 for a dental device, right? To $50 to $100, depending on what part of the country you're in and what Medicare allows. But the nice thing about this is that you can't balance bill the patient the difference. So I'm in Texas. In my jurisdiction, Medicare allows about $1,100 for this is all they allow, and they pay about $850 on it. That's it, right? So that's very difficult to do if you're going to pay $400, $500 for a lab fee for a dental device. So we could choose to non-participate. We could do this. I think our next slide goes into a little bit of that, Guy. But you have to become a DME provider to do this as well. That's the 855S application that you saw in the previous slide. You can't build that out yourself, right? But you do. Once you do that, you do have to, abide by the Medicare rules, and you still have to use the Medicare-approved devices and all that kind of stuff.
And so once you get the application and you become a Medicare non-participating provider, here's the key to it. On your 1500 form, or however your software works, you're going to have the option to either accept assignment of benefits or not. So that means, are the checks going to come to me if I accept assignment of benefits? If I check that box, then I'm going to get the check. The checks are going to come to me, but I cannot balance bill the patient. Basically, I'm becoming a provider for that one particular case. In general, in my office, most of the time, I don't check the assignment of benefits. I let the $800 and whatever it is, $50, $24, something like that goes to the patient. And then the patient pays me directly for whatever we agreed to as far as their balance on that. The supplemental check. Well, if they have supplemental in. So most of the time, I don't check the assignment of benefits. But when would I check the assignment of benefits? Is on that patient I talked about at the very beginning of the webinar. This guy who's really medically fragile and maybe can't afford the treatment. I'm not going to let that guy leave my office and have a heart attack if I can help him. We're going to go ahead and check the box. We're going to accept what Medicare allows. We've done a good thing. You tell me I don't.
On the CMS 1500 claim form, this is box 27. Okay? So you guys would have to fill that form out. This is box 27. If you click yes on that box, that means the check comes to you. Medicare is going to pay you 5% more. You can only bill the patient for the difference between what Medicare is going to pay and what Medicare allows. And again, in Texas, that's $1,150 or something like that, right? If you charge $2,000, you can't charge them the other $1,150 above that, right? So you're treated like you get 5% less. If you check no on that box, then you don't get to keep the check, right? It goes to the patient. So you might want to keep that in mind as you create your financial arrangements and you go over this with patients.
Absolutely.
So right? I mean, that's Medicare in a nutshell. You opt out, you opt in, or you kind of do this thing. And then what are the kind of remember part of this?
Remember that these you can only bill the E0486 out every 5 years. Other insurances vary, but Medicare's it's written in stone at this point, 5 years. We didn't really talk about the left side Part B because Medicare's kind of been back and forth on that. But as far as our last conversation with Medicare, they're not allowing dentists to bill for Part B side for the exams and so forth. So just to keep it safe, we're just going to keep talking about the E0486, and that's what you bill. And in order to be approved, the patients have to meet certain criteria. This is kind of the nitty-gritty of it as it comes straight from Medicare. We kind of have summarized that for you on this slide. Essentially, Medicare will cover the device if the patient is mild to moderate apnea. Basically, if they have the mild apnea, they have to have a comorbidity associated with the apnea, such as maybe hypertension or excessive daytime sleepiness. If they're in the moderate category, then they don't have to have that comorbidity. If they're severe, they have to try CPAP first. And so you've got to make sure, back to what we had on our always need side, if it's Medicare and they're severe, they're going to have a CPAP, something in the we need to know that it's been referred by a physician and it's performed by a dentist. So I do think that covers it, except for this is where you go to get started. And if you're working with third-party billers that help for dental sleep medicine, most of them will help you with this for a fee, and you very much may consider doing that because it's a fair amount of work. It's certainly not undoable or non-doable, I'm not using the right word here, for your auxiliaries to do this, but they don't have time. There's companies that will help you. And there's where you go and get started.
It is only 67 pages long. That's all.
A 2-page attention span. So.
Okay, so that's it for
on to,
okay. Yeah, on to in and out of network. So, as we build this, this is a big deal, right? I mean, if you are any of you out there in network with a medical insurance company? If you are, type it in the question box for me, okay? Because we get in front of thousands of dentists a year, and there just aren't very many people who are in network, right? What does it take to get in network, Matt?
Well, it's a lengthy process, and you've actually done it with a few. So I've heard your tale. I think one of them took you several years to get an agreement, and one of the bigger parts of the agreement is they want to pay you 2 cents for this, and you want a lot more than that. So you've got to agree to an amount that they're going to pay for each of these for this procedure, the E0486, maybe other codes that you may be able to submit. So there's a time factor in there, and some insurance companies won't even let dentists in network. Some won't let oral surgeons in network. So those are the challenges for getting in network. If you do get in network, the easier part of it is an easier billing system. We know they allow X amount, and it's just simple math. You look at their deductible, how much they're supposed to pay, how much you're supposed to collect, and you just do the math, and it's easy for you and your team. The positive also is oftentimes these patients who have in-network benefits, their deductibles are less oftentimes for in-network versus out-of-network when it comes to billing.
Yeah, usually it's about half, right? Yeah. So, but again, how you do that is you would contact the provider relations of a particular insurance company, right? And then you would start that application process. How do I get in network? I'm a dentist, but I want to get in your medical network. They'll give you an application. You just go through that. It's all your licenses and all that stuff. I think sometimes it includes a kidney as well. But if you don't do that, then I didn't get anybody to type in the question box, guy, yes, I'm in network. So, we got 40 or plus 45, 50, 55 offices on here, whatever it is, and nobody's in network. So let's talk about out of network, right? Because that's how we're going to build it. Somebody comes in with Aetna insurance into your office, and do you cover this? How much does it cost, right? That's what patients want to ask. That's what they want to know. So now we're out of network. We're not in network. You have a little bit more flexibility in how you do this, right? You are not obligated contractually to a particular fee, for example, right? And some of these vary state to state and all that other kind of stuff. So I think the plus side of this is you can get reimbursed more, right? Because you heard guys say, man, it took me years to do that. It didn't take years to get the provider relations and the contract done, but it took a long time to get the fee up to where I thought it was appropriate, right? Because they want to give you 2 cents, like I said. You want to charge $2 million, right? Well, how do you meet in the middle somewhere? That's what you do. But it does require a little bit more work, don't you think, Guy? Because you don't have that, hey, the fee's already set by the insurance company, right? Your deductible's $1,000, you met it all. They pay 80%, your part's 20%. It's a little bit more, a little bit more vague, isn't it? Yeah.
There's a lot more variance because we don't know the allowable amount. And so you're going to get different amounts based on a lot of factors there, the deductibles and so forth, but also the allowable amount. And so it can become more confusing to the team doing that.
You won't tell you what the allowable is?
And they usually won't tell the patient either. So it's hard to give a patient, here's exactly what you're going to owe. Because we don't know what the allowable amount's going to be until we submit. So you have to have a system in place where you can give the patient a ballpark figure and maybe a maximum out of pocket that you're willing to take the risk on with that patient because they want to know. They want to know what the maximum out of pocket will be. And that's how we handle it. And one of the advantages I think that you touched on, but I want to make clear, if you're in network and you don't collect from the patient the parts that you're supposed to, if you do that on a regular basis, you can be in violation of your contract with that insurance company, and you can find yourself in trouble. With this, when you're out of network, you don't have a contract that you've agreed to with the insurance company. So there's some more flexibility on that, and that's where maybe forgiving financial hardships is more allowable in the out-of-network billing system. What this really boils down to is you've got to come up with a system to what you're going to charge the patient, how you're going to come up with an estimated amount that they're going to owe, and an estimated maximum out of pocket. And once you do that, you can present that to the patient, and you're going to get a high success treatment. But what you're also going to get is a varying amount per case. You may not get the same. You may get more for one case, less for another case. And that's why you got to look at averages maybe when you're looking at how much you really want to make you happy to do this. Back to our exercise that we did earlier on in the presentation.
Yeah, I like the way you put that. The last thing, put that slide back up there one more time, Guy, before we start, because we kind of been alluding to these billing systems and what we're talking about and what we're going to talk about next. That is this exception. So if somebody comes in and they've got an Aetna PPO, okay, and you are not in network, well, it just so happens that there isn't a dentist in your town who is in network with that, right? So there is a gap in that patient's coverage. So that's what you would want to apply for. And the advantage of a gap, okay, is that the patient can now go out of their network. They can go out of their PPO network to go see Dr. Guy Yatros because he's not in network. And they get to use their in-network benefits. So they've got that $1,000 deductible instead of the $2,000, right? Like you were talking about before, guys. So the gap coverage is a very nice tool to have in your pocket as you look at what you're really trying to figure out, isn't it, Guy? How much the patient's going to pay, right?
Absolutely.
And when we get in billing systems, that's kind of how we have to think about that. We're going to give you guys a couple of different ways to look at this and how to do it.
Very good. The gap coverage is a particular part, and it can take a fair amount of whoever's doing that for the office's time. So if they're using a third-party biller, that's where they're earning their keep. If you're having your team do this and they tell you it's taking a little bit of time, it does to check on all these things. And it requires a phone call, which can take, depending on how long they're on hold, 10 minutes to an hour or more. So understand that it's a time-consuming process, but well worth it. So we're ready to talk about billing systems. Again, I know some of you have typed in questions. We're getting to those, and we'll be finished by the end of the hour here to have any questions that anybody else wants to ask. And we appreciate you all listening in. The billing systems, really, we're talking about billing systems for out of network. If you're in network, the billing system is what you agreed to with in-network insurance company that you've made that contract with. And understand that Rich has, I think, a couple of insurance companies he's in network with. So you may have some that you're in network with, and then the rest you may be doing out-of-network billing for. So there may be ways you're doing this in your office. But we talked about fee for service. That's the way I ran my desk. But you should. No. Right. We should tie in years, and that worked well for it, but it did not work well when it came to dental sleep medicine. It's just a different mindset. It's medicine, and you're going to have less cases to say yes to treatment, less patients rather to say yes to treatment if you don't at least accept. I mean by that, the check. What box was that again, Rich?
Box 27.
27. So box 27 on the form, you're going to click, and even for these non-Medicare patients, if you check that means the checks are going to come to you. And so what we can do there is we can look at how much we think they're going to allow, and we can tell a patient, this part of the check's going to come to me, we're going to pay the difference. If it doesn't pay the difference, what I mean by fixed amount there is, let's say we're going to bill it $2,000, and I think the insurance is going to pay $1,500 of it. Well, then, patient, you're going to give me $500, and that $1,500 is going to come to me. But lo and behold, I don't get $1,500. Maybe I only get $1,200. I'm going to go back to that patient and say, well, you need to pay me that $300 because I need my $2,500. And if you do that, patients aren't as likely to say yes to treatment because all they're going to know is they could be liable up to the total amount you're billing. And so what I mean by a flexible system is, look, I'm willing to take a little risk here. And whatever I'm going to bill this at, whatever I think they're going to pay, I need to set a cap for my patient and be willing to live with that. And if you do that, the chances of saying yes to treatment are a lot higher because you're taking a little bit of risk with that particular system. Anything more you want to add on that, Rich, before we talk about billing codes in particular?
I think you did that very good. Very well.
Okay, billing codes. I think we've got another slide coming up here that explains that better. If you want to be safe, Rich, what do? I think you just do the first one, don't you? Okay, there's a delay there. I know we got a little because
Sorry, can you hear me now?
internet. Yeah. You there, Rich? Yeah. You just do the 0.6 for most all the cases, right?
Yeah, for several years now, that's all we've done. You know, you can bill for some of these other things, but there's really a varying degree of whether or not you get paid for these things. So we've already kind of talked about Medicare separately, right? We're talking more about, regular types of insurance and PPOs and that kind of stuff, and you're doing this out of network. So I think, okay, as you do this, you should think about the consultation that you have to do. You should think about the exam. You should think about the impressions and the bite that you have to take. You should think about delivering the device. You should think about the 3 or 4 times you have to follow up and manage the side effects, because that's all you get to bill for the most part, and get paid. So you have to think about all of those things when you do that. And that goes back to what you were saying at the very beginning, Guy, about how long this is going to take, right? So you need to count on this taking about 3 hours as you get started, and I think it could be a little bit more efficient, give or take a little bit. But you can bill for some of these other things. Dental Sleep Solutions does a lot of billing for a lot of dentists, and we have a lot of information about what people get paid for and what they don't. I think more than anything, Guy, it's more regionally specific, isn't it? I mean, just little pockets where people get paid consistently for impressions, for example, but not across the country.
Right, and I think the key thing is that your documentation's in order as well. So some people do all right with the sleep studies even. I don't know whether you want to bill each of the appointments, but whatever you're going to bill for, you've got to have the proper documentation. Easy 0.6 doesn't require as much because you've got you can prove you did that. You've got his lab slip. You've got where you paid the lab for it. I take pictures of my devices in my patient's mouth, and so no one's going to really question whether you did that or not. All these other things, especially consultation appointments and things like that, the only proof you have is your chart notes, and they better be in order, and they better cover what the medical code says it should cover, or you're going to be in trouble. I personally do DS3 when we do that comprehensive exam, which doesn't take very long because we're very efficient at doing it with our software. I bill out a consultation appointment that day that we do the exam, and then one thing to be really important is you don't bill out the E0486 until you deliver. Medicare says you cannot bill it out at the impressions. Most of the other insurance companies are going that direction, so you're going to only want to bill out that E0486 code at the delivery. So we can do at the exam we bill out a code, and at the delivery typically, and that's the only two codes that I personally use in my practice because I think that's relatively second rich is even a little more conservative by just doing the one code.
Yeah, but you hit the nail on the head there, Guy, when you said if you do these other things, in the medical side of things, and I think that's your next couple of these slides, right? You have to use the current CPT coding, right? So that changed in October of 2015, right? You get those books, they cost about, I don't know, $150, $200, right, if you want to buy them. Thank goodness we don't have a medical office, right, Guy, where we got to use 10,000 different codes. We only have a couple. But if you're going to do a follow-up code or even a consultation, you're going to use 99203, for example. That book tells you exactly what you have to do in order to bill for that code. And then you, like you said, Guy, you have to make sure that you document that is exactly what you did, okay? Because you will get audited by medical insurance companies when you cross this line and you get into this. And we're in no way are we trying to scare anybody off from doing this. This is how we make our living, is helping dentists do this for the most part. So we want to encourage you to do this, but you just have to be careful about how you do it. If that code says you've got to check this system and that system and you've got to do this and that, then just document that that's what you've done. I think we beat that up, Guy.
Yes, we have one question that came in a little earlier. I don't know if I'm having trouble reading the questions with running the slide program, but you are not in network with private insurance. Private insurance is different than Medicare. You actually, unless you do something, you are considered out of network. It's a little different than Medicare. Medicare, you really have to make a decision in or out. You've got to make a decision one way or another. If you make no decision with private pay insurance, you are automatically considered out of network until you choose to do so otherwise. There's some other questions there we're going to get to in just a minute. All right, very good. Because we're getting close to the end, I think we're going to try to be finished on time. On the billing systems, we've gone through these, and then really, those are the questions you have to answer. I think we got Medicare covered pretty well. I think we did the in and out network. And then the billing system, I know we didn't give you specific billing systems as far as flexibility and flexible systems and how you come up with those amounts. That really kind of depends on a lot of factors that really need to be discussed to really come up with that specific. And that's why we offer insurance billing in our association, DS3. We do that for you. There's other offices, other insurance billers, third-party billers we can hook you up with as well. Thank you. You really just need to have a system that everyone in the offices really knows and no one gets confused. I think that's the biggest problem is that anybody's going to be talking to that patient about money. You need to be comfortable with this. They don't need to be him-hawing around and well, I don't know how do we do this, and the last patient we did this with, you've got to, as Rich likes to say, taught me to fake it till you make it, and act like you've done it before, and have a system that the patient seems that he's comfortable with everyone in the office. And I can tell you, it makes a difference. The less they have to pay, the more cases you'll do. In my practice, for years, I did just like I did a dental practice, cash up front, check with the patient. Less than a third of the people I saw from consultation said yes to treatment. I track these numbers. I'm very big about tracking numbers in my practice. Once I at least accepted some of the money from the insurance and let the patient pay a portion, we were near 50%. But once I became more flexible or allowed patients to have a maximum amount of pocket, and if the patient runs treatment, I want them usually to pay me something because I think they'll value it. But I found that if in worst case scenario, go down to about $500 out of pocket and take the risk on what I'm going to get with and I'm not saying I do that on every case, but if I need to do that, and when they need it, and otherwise we collect other amounts, we're pushing 3 out of 4 patients saying, yeah, care about the patients and have a system in place. So I hope that you're excited about saving people's lives, because that's really what we do. If you come to one of our seminars, we can share with you story after story about how we help people live better and literally help them live longer. And some of the earlier stories where maybe that didn't work out, and that's what it keeps us going. And on top of that, you can make money doing this. If you only did 6 devices a year, and you got a lab cost of $350, which is $50 more than the clear dream. And even if you're doing an average amount of around $2,500, even if you pay for DS3, which again you want a free trial, just type in free trial, we'll give you one for the next couple of weeks. No obligation whatsoever. We'll show you what we can do for you. The free trial, you can be down to 10,000 a year that you're making. 6 devices a month, you're at 10,000 nearly, 9,300. 1 a month, you're at 22. You can do the math. You're at 4 a week, or 4 a month rather. You're up almost to 6 figures. So hope this helped you. And that you're the expert now on billing. There's what we do and what the free trial will be involved. And I think in case you joined us a little bit later, we do these hands-on courses. We do 2-day courses. You get a sleep study, home sleep study. The doctor gets that. The doctor also can get 1 dental device made as well, and 2 days of CE, a day and a half goes till about 1 o'clock the second day. $9.99 is our normal fee, and I don't think we've ever offered this before, but it's our Cyber Tuesday special. Type in, if you want to go to one of these courses and register by tomorrow, we're going to take $300 off that. I think I forgot to mention, you even get to bring this for that too. So, for $700 roughly, you can't beat that. So we promise you'll enjoy the course and learn a lot.
Ray, what do you think? We get in front of a lot of dentists every year, when we do this. What do you think the difference is between the guys that come to our course and we talk to them, right? What do you think the difference is between the guy that takes it? That's not a sexist statement, right? The gal, we have just as many women that are successful as men, but the gal that takes it and runs with it and is successful, and the one that really struggles. What are there common themes to the one that's successful as opposed to the one who's not?
Well, other than the fact that we teach you how to be efficient at doing this, and so if they come to one of our courses and they're using our system, we have very, very high success rates. Other than that, I think taking the time, we do have a great system. It does take some effort on your part, and I think team members who are dedicated and the more team members that come to these courses and get involved in our systems help too. So I think understanding how to make this efficient and each little piece put together, that's exactly what we do. Help them do that so that it's not just this big unknown. And having team members who are accountable, yes.
I think that's a good point. Well, I think that's a good point. I think if you guys have to understand a couple of things, I would maybe add to that guy would be you have to understand there's a learning curve to it. You had that slide up in the beginning, right? Change is a process, it's not an event. So it's a process to learning this. It's a process to implementing it into your practice. I think one of the common things that a dentist be successful is they break out a half a day a week, and all they do is dental sleep medicine. That you don't have that, hey, Dr. Yatros, you got a hygiene check. Dr. Yatros, you got to numb the patient in two. Dr. Yatros, you have an emergency coming in. Dr. Yatros, this. You just go, okay, most dentists don't work Wednesday afternoons or Fridays, right? So take half a day and just do dental sleep medicine. And if you don't have any patients, then call up a couple of doctors in town. Go visit them. Log into the DS3. We have a complete 10-step system there where you get an online course, right? You get 10 units of CE for it, for your AGD and stuff like that. You're doing something that relates to dental sleep medicine during that week. Do that, 6 months from now, you're not sitting around doing nothing anymore. You've got a marketing plan in place now. You've got, brochures. You've got posters up in your office. You've got, you're working on it, but you're not trying to fit it into every single other in between all of your other patients. I think that's a good point to take away from this.
Yeah, and we have our 10-step program that's designed to do just that. It helps walk through these staff meetings, team meetings. Here's what you need to know. Here's the next implementation step. And that I really excited to put together a unit really help fill in all those gaps and to get the offices up and running. So look at that, Rich. We're done on time. I'm pulling up the questions. I think I finally figured out how to get the box expanded there. Looks like you've done pretty well at answering a lot of these. We're going to put our contact information up here so that people can have that as well. We hope we can help you. Again, if you want to do a free trial, I'll type that in. If you want to come to one of the courses at that steepest discount, we can sign you up. I see that. I think we have a program coming up in the 3 of them next year, and something more than what we schedule. Is there any other questions, Rich? If you've got a question, type it in or raise your hand.
Yeah, I'll stay on a couple more minutes, Guy, and answer these questions if you want. I mean, we really want to encourage you guys to do this. We really do, and we try to give you a couple of tips there, between the two of us, Guy, what do we have now? 25 years or more, doing this, 30 years, something like that, of doing this.
I think it's around 25, yeah.
Yeah, I have made thousands and thousands of these devices. So you've got to to get a system, you got to have a plan, all of that kind of stuff, and just take time to implement. Nothing's going to happen, right? Unless you work at it. So.
Right, and we make all that easier. I see a question here. Do we like the handmade appliance? Sure. We like that appliance a lot. It's one of the least expensive ones. Keller's fee on that is one of the least expensive of the EMAs, and it's a good appliance for the cost, and it's very comfortable. It fits on a lot of a patient's needs. Some patients it's contraindicated for, and maybe heavy flexors and things like that, but I personally wear it sometimes. I kind of mix my devices up and wear one now, other ones at times just to mix them up. And a lot of patients really like that. It's small. They don't. It doesn't show if there's newlyweds or something like that. So it certainly has its place. We're going to be doing more of these courses in the future, and next year we're going to have a schedule set up. But in the past, we've always done some on device selection. We did one for Keller on device selection a few months ago, and we have 4 devices that we do quite regularly in the EMA as well.
Yeah, we had one more question, Guy, there about what's the most comfortable device. How many of you worn, Guy? I've maybe worn 6 or 7 different ones. And what we have to remember is, my personal experience isn't the same thing as a patient's, for example. So, it's a little bit of a loaded question. So, a tap is a comfortable device, okay? But if you got a class 2 bite and it's very deep, a cap is not always the most comfortable device, right, guy? Because you got to open the vertical so much, right, to get it. In that case, an EMA might be more comfortable. So I think as a general rule, I think the dorsals are probably, in the EMA are probably the more comfortable. What do you say, guy?
Yeah, AMA's up there on the dorsal.
But it depends.
Yeah, you're right. It has to do with the patient. Yeah, I mean, but two comfortable ones. And, I think we all think this an awful lot. When we do our course on our 1 hour webinar on device selection, we'll give you a little clue to how it starts out. We show a dartboard and say you can use this for most cases. And the truth of the matter is, if you only had one device to select from, most patients would wear it comfortably. If you only had one car to drive and there weren't all these choices out there, we'd be fine. We'd get to work. We'd get to where we need to go. But hey, I like this one better. I like that one better. Once the moment there's choices in anything, it makes it a little bit more complicated. Let's don't overthink it. The device selection, although I don't say it is unimportant, it's probably one of the least important things that is oftentimes overthought about, overcomplicated. These devices all do the same thing. They move the jaw forward, they keep the jaw from falling back, and they keep the airway open. Most people can get used to most of
them. Good point. Good point, guy. Okay. I smell that shrimp cooking in the other room. So, the last question, plane are matched to weird. And so if we think about our dental devices, we think about CPAP. Our dental devices treat snoring better than CPAP does. Okay? So 95% of the time, our dental devices will move a patient 6 points on a 0 to 10 scale of snoring. Okay? So if the patient comes in at 10, we tell them 95% of the time we're going to get you to 4. So that might have been a talk with this particular patient where had you had that talk before, they might not be disgruntled. So they come in and they have a problem with snoring. Well, rate your snoring, right? Again, this is where a questionnaire becomes invaluable as you do this, right? And that's what Guy and I have spent the last 10 years of our lives designing and putting together through the Dental Sleep Solutions of the DS3 system. So, yeah, from a Latin thing, then they're more accepting of what's going on. The other thing I would say that you can do that really helps with the snoring is to increase nasal patency. We use nose cones a lot. Okay, you Max Air nose cones. You get them online. They're $25. They come in small, medium, and large. We make a lot of referrals to ENTs, right? Septoplastics, terminectomies. Things like that. So you can always do that. There's probably not a lot more you can do if you're at 90%. Sometimes you can get a patient to go out a little bit farther if you work with them slowly. Yeah.
Hey, Rich, that's exactly the way I would answer that question. They're almost verbatim. The only thing I would else suggest is when it comes to the nose, to look at allergies. I'm recommending, as long as their physician doesn't disagree, that they can buy over-the-counter nasal cord, that they have all that stuff's available. Nasal steroids are available over the counter now, and those help in addition to the nose cones. And then lastly, if it's a device like a dorsal design, adding elastics can help as well. It can help promote more nasal breathing as well, and that can make a huge difference.
Very good, guys. I haven't forgotten about that. Rosa, what kind of device are they in? I mean, you said they came from CPAP. Their HI was 8.3, right? So, maybe nasal patency like that. I can tell you that the updated practice parameters that the AASM and AADSM came out with is says that the dental devices treat snoring better than CPAP does. So that's looking at more than 10 studies that do that. So, you might have something that's a little bit different. So, guys, she's in a SomnoMed Fusion, so that might be a great time to add the elastics.
Absolutely. It could make a huge difference.
You're not using it.
It can make a huge difference. And the last thing we'll say, these don't always do everything. I mean, dental sleep's not 100%. We don't 100% time We help thousands of patients. It's very rewarding, but it's not 100%. And sometimes we have to say, hey, we're a physician now when we're doing this. The doctor sometimes has to look at the patient and say, hey, you know what? We've done all we can here.
Well, except here's Rosa. She says she's fitted nose cones, right? He can still make a snore with the nose cones in. That doesn't mean that you can't, do all of these things together. We're going to do the best job that we can, and that's where knowledge is power, right? So it sounds like you're doing some of this stuff, right? And you may get to the point where you go, you know what, that's as good as it gets. Because remember, snoring can be very nasally, and it can be very high, and it can be very palatable, right? There are some home sleep testing devices that actually measure the frequency of the snoring, and they can tell you if it's more palatable or more nasal, right? So in that particular instance, right, it sounds like you're doing about the best that you can, and
Absolutely.
give it 3 or 4 weeks and go from there.
Hey, Rich, we got another question about billing, and this is a billing webinar. I know we're running over, but we're happy that we just pulled over to answer this question. So Eric has a question I think we should answer because it does have to do with insurance. I see someone has some hand raised too. So I'll stay on there as well because we need to get these answered. How do you bill gap coverage is the question for out-of-network patients. We have a whole billing department that does that. I've never personally done it. It's a phone, and when you're doing the verification of benefits and you're asking if they need pre-authorization, one of the questions you ask is, do you allow for gap coverage? And they'll tell you. And so, what are the coverage amounts? What's the percentage that they pay? For in-network.
Here's another one, guy.
If you want your crystal ball, is the crystal ball fired up? Get dust off the crystal ball and let's see what we say. But I know that I doubt that you have the answer to that, do you?
Well, I'm 54, and hopefully I'll outlast it, right? I'm not going to practice too much longer. So I don't know what's going to happen, man. I mean, I don't think any of us know. I think at some point, okay, you got to remember in the big scheme of things, okay, our dental devices are gaining traction, gaining ground every single month for the last several years. We are getting more and more of the market share to treat patients who have sleep apnea. And as that happens, these HMOs are going to have to deal with a dentist at some point and how to do this. And then as a dentist, we got to decide if, just like we had to as dentists, right? Are you signed up with a bunch of plans now? Well, yes, no. We're going that same thing that we are dealing with in dentistry, we're going to have to deal with in medicine. And I'm just hoping we get a president in there that can kind of change some of this, to be honest with you.
Right. Well, let's not go down the political road here tonight, but although I may agree, yeah. Well, I think that looks like that's it for the questions. I don't see any other hand
Can I do
raised.
one more guy here? Can I do
Sure,
one more
buddy, go ahead.
reimbursement time? We didn't get to that one.
I didn't see that.
It seems like it's all over the place. It could be our third-party billing, but I'm not sure. Could be, Rose, it could be your third-party billing. I mean, what we try to do is we try to file a claim electronically, okay? And then about 2 weeks later, we try to follow up with it, right, to do that. So the squeaky wheel gets the grease. If you're filing an electronic claim and you're touching those claims every 10 to 20 days, then it shouldn't take more than the days or so to get paid. Okay, if it does, then somebody's not calling on that claim. Somebody's not following. You get CE
Very well. And Emily, yes, you do. And how that happens, we have your email, and we'll get the CE credit for some reason. You don't get that, feel free to contact us at Dental Sleep Solutions. But that happens kind of behind the scenes, and I don't know the logistics on that off the top of my head, but yes, you do get CE credit for this webinar if you choose. Is that it, Rich? Is that all of them?
All right.
Thank you. You're welcome. Thanks
Thank
everybody
you,
for
guys.
staying. Yeah, all right. Well, thank you for your help, and everyone have a good rest of the year. We'll continue with some other webinars at the first of the year, which we're working on our schedule for those. If you're on our list, you'll get the notices for those, and I'm sure we'll have one likely starting in January, February. We'll be finalizing that in the next few weeks. So everyone have a good rest of 2015, and try to come to one of our CE courses. Let us know how we can help you. Just contact our team if you even just have a question. We're here to help dentists do dental sleep and get more patients treated for sleep disorder breathing and apnea. So have a good night.
Okay.